So then the issue comes up is, what do you do second line?
So this is a challenge because I think you do sort of go all in on first line when you use the 3-drug combination, and then I think the standard approaches would be docetaxel alone or with ramucirumab are the 2 options. I generally do docetaxel, ramucirumab, maybe in the better performance status, younger patients. I have some doubts about the incremental benefit, but the trial was positive, so I think it is an option to consider. I think the challenge we also face is patient enthusiasm for docetaxel is going down. You know, I think when you go in and talk to the room and that's what you have to offer, it's a little bit disappointing to the patients, especially the ones referred in for a second opinion or other option.
Lior, your thoughts, second line at this point?
So outside of trials, yeah, we're back to docetaxel ramucirumab. We've always used the Japanese dose, so the 60, which is a little bit better tolerated. But right now there's, you know, not a lot of good options. And even many of the trials that are coming out looking at IO failures in lung with the next generation of drugs have not looked that promising.
Yeah. So let me, Max, you have a comment?
I think we have 3 options in this situation. We can do a reinduction with platinum doublet. The problem is, should we add also IO in this situation when we used IO again? The other hand, in Europe, we have the opportunity to use nintedanib in this situation also instead of ramucirumab. It's oral and it's I think from my point of view, better tolerated, and you have nice data for the fast progressors.
Yeah.
And on the other hand, we have the possibility in clinical trials to switch from a PD-1 to a PD-L1 inhibitor also. I think those are the 3 options we have to choose. For docetaxel, I'm completely with you in line that it's not well tolerated. Quality of life counts. Patients are coming from IO, switch to docetaxel. We sometimes use it weekly, or the 60 milligrams are better tolerated. But it's palliative care, quality of life counts, and docetaxel, I think it's not the nicest drug in this situation.
So that brings up a point. If that's the option and there's some hesitancy or really lack of enthusiasm for docetaxel as a cytotoxic drug, do you hang on to immunotherapy? Do you treat through progression? You know, what's the impetus to switch when what you're switching to is, you know, we're not doing it with a great deal of enthusiasm? Do you treat beyond progression, Tom?
I don't continue the immunotherapy beyond progression. I think generally, but I'm also very diligent to make sure it's true progression, you know, and that not an ambiguous CT scan or something like that. But I think, to my knowledge, there's not data that continuing immunotherapy through multiple chemotherapy platforms is beneficial.
Lior?
Yeah, I mean, the reality is when these drugs are in the system, they hang around for a long time.
Right.
I mean,
and their effect, I mean, we know that the effect on the, you know, we have people that have maybe discontinued treatment because of toxicity and that the benefit can go on. That's a different situation. But to your point, the effect may be long lasting.
Yeah, I mean, you see, we've had people with complete responses to docetaxel because they had IO and progressed in IO. I think we're going to get that answer if the cooperative group trial ever opens. The ECOG-SWOG trial that's looking at carbo-pembro and pembro alone, and then on progression, some people will continue. So if that trial finally opens, I think some of these questions will be answered of should you continue versus stop. But for now, I don't think there's any data to continue the IO agent.
Beyond progression. Yeah.